Right. Moving on, I would like to introduce our next speaker, Dr. Elliot Newman, who is a professor in the Department of Surgery, and he is going to talk to us today about the surgical management for pancreatic cancer.
Okay, thank you. Where's the, run it off of this?
Yep.
Okay, and just the usual enter, right? Okay.
Yeah, you can even use the arrows if you want.
Okay. Okay, good late morning, and thank you for the opportunity to discuss with you a little bit about how we manage pancreas cancer from a surgical point of view. I'm sure I'll cover a little bit some duplicate facts that Dr. Gross mentioned to you, but I guess it's always good to reinforce some of the important points as it comes to pancreas cancer. As you can see from this data from statistics from 2016, the numbers for pancreas cancer, it's not the most common cancer in the United States, and certainly not one of the most common gastrointestinal cancers that we see. It doesn't even make the top 10 for men. It's on the lower point for women, but as you can see, it is very significant in terms of the amount of deaths from pancreas cancer, and that's why it's something that we work very hard at to cure, and we work very hard at to get as early as we can. These numbers are going up, unfortunately. In 2016, over 53,000 cases of pancreas cancer are predicted. I've been giving this kind of a talk for many, many years. Used to be in the 37,000 range. So part of the reason it's going up is because we're better at detecting the disease. Some of it may be related to some environmental factors. The average age you could see, it's a little bit more common in men and African American men specifically. The function of the pancreas, it's located in the mid-abdomen and has different parts, as you heard from Dr. Gross, the head, the neck, the body, and the tail. It produces enzymes that help us digest fats, and it also produces hormones that help us in blood sugar control. Some of the risk factors, which I'm sure Dr. Gross already went over, for developing pancreas cancer are listed here. Probably the number one these days on this slide is smoking, something that obviously we can control. And you can see some of the other factors. And this is the biggest problem when it comes to pancreas cancer. It's very hard to detect. There are no great tests. There are no good screening tests. And because of that, it often is considered to be a silent disease. Probably one of the most common things that we see is unexplained weight loss, for example, but weight loss could be due to a lot of different factors. So it's not easy to pick it up in its earliest stage. You heard Dr. Gross talk about some of the symptoms. Jaundice, when you turn yellow, is something that is more common with tumors that are in the head of the pancreas. And if we see those tumors, we tend to see them earlier than tumors that are in other locations in the pancreas because of the development of jaundice. Pain, floating stools, weakness, loss of appetite, nausea, vomiting, and unexplained weight loss are some of the other factors that might tip off that something's going on. But as you heard Dr. Gross say, that's not the most common reason for these symptoms. It's usually something benign. It's usually related to something else going on. So it often takes a while till people will get diagnosed with this disease if the symptoms are from pancreas cancer. And this is the biggest battle that we all face. A very small percent of people present with local disease. Most people have regional disease or more distant disease, and I'll talk about that a little bit more as it impacts on surgery. So the treatment of pancreas cancer depends on the stage, and very, very commonly in the majority of situations, we use more than one modality. Surgery, radiation therapy, chemotherapy, or the combination of all three are used to treat the disease. It's very rare to use just surgery alone. Whether chemotherapy or radiation therapy is given before or after surgery is a bit of a debate these days, but either way is acceptable, and a lot of it depends on the program at a particular institution. Certainly, if we can get it in an early stage, obviously, as one would expect, we have a much higher chance of curing the disease. And this slide is probably the most important slide in terms of how to decide where to get treated for a disease like this. You really need a multidisciplinary team approach, and Dr. Gross alluded to that. You need surgeons, you need medical oncologists, you need radiation oncologists who focus on the cancer aspect of things, but you also need someone like Dr. Gross, a good gastroenterologist, nutritionists, and radiologists and other support staff who are all very familiar with the disease and know how to handle it. One of the biggest misconceptions about this disease is that once people are diagnosed with it, that it's too late and surgery is not going to help, and there's thought out there that the surgery to do it is very morbid surgery and people won't be able to tolerate it, especially in an older group of patients where we often see this disease. This was a study that was published in 2007, and it shows you that 70% of patients with early stage, potentially curable pancreas cancer did not have surgery. And if you look at the reasons, as expected, there's always going to be a group of people who are not medically fit. Some people didn't want surgery. A small group were told that they were quote-unquote too old, but age in of itself is not a factor. I've operated on people in their late 80s, even someone in their early 90s. But if you're in your early 90s and you're a fit person, I'd much rather operate on that patient than someone who's in their 60s who's not so fit. So it's really about your heart and lungs and other comorbidities rather than a specific number for age. As we all know, 90 is the new 70, 70 is the new 50. So age really doesn't mean much anymore. But in 38% of patients, they were not even offered surgery because the physicians taking care of the people thought that it was something that shouldn't be done without really good understanding of why it shouldn't be done. If we look at pancreas cancer surgery over the last 40 or 50 years, there's been progress in various ways. In the 1970s, when the operation was becoming maybe a little bit, it was originally described in 1935, but over the years it became more and more popular. But even in the 1970s, the mortality, the chance of dying from the surgery was pretty high. 1 in 5 patients didn't make it out of the hospital. And when you have a disease where even if you have successful surgery, the chance of being cured is 1 in 5, it's hard to do an operation where you're going to have such a high mortality. And in 1986, a surgeon out in Colorado said it shouldn't even be done because the outcomes were not so great. But then in the 1990s, we got much better. Training was better, anesthesia is better, selection of patients is better. So we can manage people who are older and sicker much better than we could 30 and 40 years ago. And so the mortality now is at most 1 to 3% in institutions that do a lot of it like we do here. And probably what's developed in the last decade or so is the minimally invasive approaches. Some of these operations can be done with little incisions and the hospital stay is less, and the benefits of that kind of an approach. The key issues for me as a surgeon when it comes to pancreas cancer and what we need to think about: who's a candidate, what are the goals of surgery, what kind of an operation do we do, what are the immediate postoperative risks of surgery, and what are the long-term and short-term outcomes from this kind of surgery. So again, to reiterate, when we talk about who is a candidate, you have to be medically fit. Again, age in of itself is not an issue. So if somebody has a disease and they're in their 80s and somebody says, "Are you too old for surgery?" that's really not appropriate and not true. It's a matter of getting evaluated, and if somebody is medically fit and has the ability to tolerate it, we've published our own data from here. People over 80 do just as well as people who are under 80 if they're properly cared for and selected. We don't want patients to have any distant spread of disease. If the disease has already spread outside the pancreas to distant organs, then surgery is not going to be able to help that situation. And we'd like to completely remove the tumor. We don't want to leave any behind. That gives us the best results. So this is a picture of the pancreas. It's nestled in to the duodenum. Is there a pointer? Ah, there it is. Okay. So here's the small intestine, which sits right on the outside of the pancreas. And tumors can be defined for us as surgeons in one of three ways. A resectable lesion is one which is just completely within the pancreas. It's nowhere near the major blood vessels that run near the pancreas, and it hasn't spread outside the pancreas. That's our best scenario. That's our best situation. And we can operate on those people, but even in those settings, we'll still use sometimes chemotherapy or radiation prior to operating. This is what a CAT scan of that situation may look like. This is the pancreas tumor here in the head of the pancreas, and you can see that it's well away from these key blood vessels. This is a vein, and this is an artery, and there's a nice area of separation between the tumor and those vessels. That's where we have our best outcomes. The one that we struggle with a bit more is what we call borderline resectable. Those tumors are actually very close or impinging on the blood vessels that run near the pancreas. And the ability to completely remove those tumors is less than it is for the group that I showed you before, the resectable group. And so in these situations, we just about always will give treatment beforehand. And I'm sure you're going to hear later from Dr. Leishman about these kind of treatments. And on a CAT scan, you could see, whereas in the other case, the tumor was well away from these blood vessels, here you could see how this blood vessel has changed its shape. It almost looks like a teardrop. And that's because the tumor is pulling in this blood vessel. And it's right next to the artery. And so these situations are much more difficult for us surgically, and we will need help from our colleagues in radiation or medical oncology to try to get these into a situation that we can operate on. Finally, the ones that we can never remove are the large ones that completely encase these blood vessels. And these are situations where, as surgeons, we really don't have any options, and those are ones that are treated by our colleagues in medical and radiation oncology. And here, you can't even see those blood vessels that you saw in the two previous CAT scans because it's completely obliterated by the tumor. This is an example of what we see by laparoscopy. Sometimes these tumors can spread to distant organs. It's not always easy to see it on a CAT scan, but if we're not sure, we'll put in a laparoscope and do staging, as you heard from Dr. Gross, and we'll see these little spots on the liver. This is a situation that, again, is not amenable to surgery because the tumor has already spread outside from the pancreas, and we know that surgery is not going to be curative. And again, we would refer you to one of our colleagues in medical oncology to help in that situation. The goals of the operation, of course, we would like to cure people when we do the surgery. And again, that's generally only with the resectable lesions that are well away from the vessels. But there are some situations where even if it's in that borderline resectable group, with the help of medical or radiation oncology, we can shrink the tumors and then also operate for cure. Sometimes we'll have to do relief of symptoms even if we can't cure patients. Patients who are jaundiced these days most of the time can get fixed by someone like Dr. Gross who can put a stent in, but once in a great while we still have to operate. If the tumor is blocking the intestinal tract, sometimes we have to bypass the tumor, and if there's significant bleeding which cannot be controlled in any other way, then sometimes we have no choice but to operate in those settings. But those are rare instances for us operating on pancreas cancer in the year 2016. The operations that we do, you may have heard about something called the Whipple operation. That's where we take out the head of the pancreas, and I'll show you a picture in a second. Sometimes we'll take out the end of the pancreas, or what we call a distal pancreatic resection. So depending on the location of the tumor, in red here you see tumors that are either in the uncinate, in the head, or in the neck of the pancreas. And very commonly those tumors are handled with the Whipple operation. We have to take out this area here. Because the blood supply to the pancreas and to this portion of the intestine, you can see the blood vessels right here, are one and the same, we have to take out this little piece of intestine as well. And in this area of the pancreas, the bile duct comes out from the liver through the pancreas into the intestine, so we have to resect that piece of the bile duct as well. For tumors that are located in the body or in the tail, then most commonly we can just divide the pancreas somewhere over here and take off this side of the pancreas. It's a little bit of an easier operation. Sometimes, however, again, because the blood vessels to this part of the pancreas are the same blood vessels that go to the spleen, we have to take out the spleen as well. And that is very well tolerated in patients. There's very little downside to taking out the spleen, especially in adults. So if you look at this diagram here, everything in gray is what gets removed when we do the Whipple. This is the head of the pancreas for a tumor that's located in the head, of course. This piece of the intestine, this piece of the bile duct, which runs through the pancreas. And then we do a reconstruction, we reconnect, we take the intestine from further down in the abdomen, in the stomach, and we reconnect to the remainder of the pancreas. We do not generally take out the entire pancreas when we do this kind of surgery. We connect to the remainder of the bile duct, and then there are two options. Some people will resect part of the stomach when they do the Whipple. Some people will leave the entire stomach. That's how I prefer to do it. Either way, it's fine. But with these three hookups, then the juices from the pancreas and the liver will get back into the intestine, and you'll eat normally again through the stomach. And people actually, once they recover from surgery, really do quite well down the line in terms of eating and gaining weight and getting back to a normal life after this kind of surgery. If we're doing a distal pancreatectomy, taking out for tumors that are in the body or the tail, then after we free up the pancreas, we'll divide it here and take out this side of the pancreas. And again, very often the spleen will be removed as well because of the blood vessels that are going underneath the pancreas into the spleen. Minimally invasive surgery is something that's come along. I mean, it was originally described in 1987 with laparoscopy, and the field has advanced tremendously in the 30 years since it's been introduced. And today, we also can do now robotics, which was introduced in the early 2000s. We've been doing it here since 2009. And for certain pancreatic operations, I'll do things on the Da Vinci robot. It minimizes recovery because you have smaller incisions and less trauma to the abdominal wall. It also helps us in diagnosis and staging. And again, some of the tumors, especially for the distal pancreas resections, can be done laparoscopically. There are some people who even do the Whipple laparoscopically. I personally do not, but we do have people here who do. And this is a picture of what laparoscopy looks like. This is instruments within the abdomen. A camera looks in, and on the screen, we can take a look and see what we're doing. And I showed you earlier that picture that demonstrated what we might see on laparoscopy. And this is now what the robot, the Da Vinci robot, looks like. Again, this has been around since the early 2000s. We now have the latest machines here. We have half a dozen robots here at NYU. We're one of the busiest programs around. We use it for a variety of things, including general surgery and including some types of pancreatic operations. The immediate postoperative risks relate to cardiac issues, pulmonary issues. You can get infections, you can have bleeding. The most common complication that we see is a fistula, which means leakage from one of the hookups that we do. The most common is the pancreas hookup. The biliary hookup or the stomach hookup's much less common for them not to heal properly. But even if the pancreatic anastomosis, the hookup, doesn't heal perfectly well right off from the beginning, it seals usually off on its own, and it's very unusual to cause major problems down the line. Long-term nutrition eventually pretty much gets back to normal. People gain their weight back. There are issues with something called dumping, which means if we take out part of the stomach, there's less stomach, food empties a little bit more quickly into the intestine, and there can be some symptoms that go along with that. Again, generally well managed and usually not a problem. And if there's any issues with pancreatic function, we can give enzymes to supplement that, and we can give diabetes medications if we need to. So these generally, again, do not get in the way of recovering from this kind of surgery. The most important thing to take away from this when it comes to surgery is that experience counts. This is a study that was published back in 2002, which demonstrated that in places that do only one Whipple a year, the mortality, the chance of never leaving the hospital could be as high as 16%. And you can see the more you do, the lower your mortality. Here at NYU Langone, we've published that our mortality is under 1%. So we're very comfortable in doing this operation. We have a great team that works together to make sure that everybody gets through this as safely as possible. So in summary, pancreas cancer is a very challenging disease to cure and has an insidious presentation. The most important thing is to make sure that you're treated by a team of people who understand the disease well and work well together. Resection is the best chance of being cured, but resection in of itself or alone is generally not enough, and that's why we rely on our colleagues in medical and radiation oncology to help us. We are much more aggressive surgically today than we were 20 and 30 years ago because we're better at doing the operation and we understand the biology better and we know how to do things better than we did a long time ago. And the most important thing is to make sure you're treated at a place with a lot of experience that sees a lot of these tumors and operates on a lot of them, because it is something that clearly demonstrates that you'll do better with more experience and more volume. Thank you very much. I guess we'll have questions at the end for your time.